Good evening. Welcome all viewers today's Cross Connect webinar on diabetes and effect on mental health. To discuss this important topic, we have two eminent speakers, Dr. Amritpal Singh Sodhi, who is MD Medicine, consultant diabetologist, and fellowship in diabetes management from CMC Vellore. And our second speaker is Dr. Sumesh Khanna, who is MD Psychiatry and also member of Fellow of Indian Psychiatry Society and a member of American Psychiatric Association. So I welcome both the speaker and I request to Dr. Amritpal Sodhi. So sir, over to you.
Yeah, can you share the slides, please?
Yes, sir. Hello. Dr. Amrit, sir, you are not audible. Hello. Sir, am I audible? Yes, sir. Dr. Amrit.
Yes,
Sir, you can start.
yeah, but I am not seeing the slide right now.
Sir, can you just stop your video? I think you're.
Yeah, I have stopped it.
Yes, sir. Sir, now it's visible.
No slides are not visible.
Uh, Dr. Sumesh, hello.
Yeah,
Sir, slides are visible.
no,
Okay, now the slides are visible.
yeah, they are now.
Yes, sir. You can start.
Yeah, okay. Good evening, everyone. I welcome you all to the wonderful meeting on the diabetes and its reflection on mental health. And today evening, I, Dr. Amritpal Singh Sodhi, consultant diabetologist from Moga, and my senior colleague, Dr. Sumesh Khanna, who is a very renowned psychiatrist from Moga, we both will be discussing some topic on the management of mental health issues and its prevalence in the scenario of present diabetes status in India. The diabetes and its reflection on the mental health, when we just go for the very start, diabetes, it is disease, can be controlled by discipline, but if not treated properly, it can lead to severe depression and ultimately death. The focus on diabetes, depression, and risk of dementia, it is the today's talk. Next slide. In the mental health issues and diabetes, there are multiple risk factors which involve unhealthy lifestyles such as diets high in processed sugars or fats, inadequate activity and sleep. The patients who are more sedentary and who are lying more on the bed as couch potatoes, or who are having poor resources like low income group, low education group, unsafe neighborhoods, or poor health literacy, or the patients who are having chronic stress responses, who are having type A personality, who are continuously remaining in stress because of any kind of factor known to them, they are more prone. Next slide. In the depression and diabetes link, the common is more than 10 to 30% of the patients of diabetes, they suffer from depression in their lifetime, and the depression associated with the worst biomedical outcome. It is having 2 to 3 fold increase in the mortality, and it is underdetected yet highly treatable. When we go for the issue that depression is underdetected but is highly treatable, we have to explore from the very beginning all the patients and who are having any kind of depression associated, so that we are able to treat them right at the very beginning stage. Next slide. The prevalence of depression increase in diabetes versus no diabetics. When we go for the large data, the 1 year prevalence of depressive episode in diabetes was 9.3% as compared to 3.2% in without diabetes. And in the primary care, the 4 to 15% they have major depression, and 9 to 16% they have other depression. And diabetic population, which include impaired glucose tolerance patients, the pre-diabetics, the diabetics. They all contribute around 15 to 30% of the total population. And in the meta-analysis studies, the 13% versus the 15% odds ratio is around 2.0, such as more of the diabetic women, they're having diabetic depression in comparison to men. And clinical versus community samples, the odds ratio is 32% and in comparison to 20%. The self-reported patients of diabetes depression are 31% in comparison to when they're detected in the interviews. Next slide. The depression is associated with all stages of diabetes, and the odds ratio in the pre-diabetes is 1.60, but the mortality as a hazard ratio is more than 2.0 to 5.0 when it is going for the complications, and at the suboptimal glycemic control, it is effect size is 0.17. If we start from the pre-diabetes to the diabetes and the for the suboptimal glycemic control to the complication, there is number of factors which are adding up to the mortality when it is associated with the diabetes and depression, and ultimately leading to dementia and death. Next slide. The common mechanisms for the depression diabetes link is in the psychological process. Dr. Sumesh Khanna will be discussing a lot about the things. It is having diabetes specific distress, the depression, impulse control, or the satiety control. And as far as the biological molecular level is concerned, we are more concerned about the hypothalamic pituitary axis, the inflammation, the autonomic nervous system, early life programming, antidepressants, and their role in the diabetes depression, or the circadian clock, or the gut hormones and satiety, the sleep apnea, or the mitochondrial factors, which is contributing to the diabetes and depression, and ultimately dementia and death. Next slide. The depression and type 2 diabetes, when we go for the search for the common origins, it is common in type 2 diabetes. It is having increased mortality, and it treating depression alone does not improve glycemic control. And from the very beginning, as the fetal nutrition or the genomics or the lifestyle or the social adversity, when the depression adds to the diabetes, ultimately it is a progressive disorder, and we are not able to come back even with the help of the proper control if not detected at the time of the very start, and if we are not able to detect it in the beginning and the right treatment is not started at the right time. Next slide. Both depression and diabetes is associated with high risk for all-cause dementia. The long-term hazard ratio is rose to 42% higher at the 10 years post-diabetes diagnosis. The mechanism suggested again is same: increased inflammation, decreased insulin sensitivity, autonomic nervous system dysregulation, ROST. And the magnitude of the association of depression as well as comorbid depression and diabetes with restful dementia was more pronounced. The more are the years of diabetes, the more is the risk of the diabetes, which is associated with dementia and depression. Next slide. Both depression and diabetes is associated with a high risk for all-cause dementia. When the risk of all-cause dementia among depression alone or the diabetes alone, when it is compared with the diabetes and depression and compared to persons with neither disease, in the last paragraph, it is the graph which is showing the hazard ratio of 2.17. We are having in this the age, the mind depression showing my depression, the diabetes alone, and the number of hazard ratios. It is varying from 2.17 to 1.88 to 2.07 to 1.82 when the age is added, when the gender is added, when the mortality risks are added, ultimately causing the more of the hazardous risk for the patients who are having multiple causes or the multiple comorbidities with diabetes. Next, the diabetes and depression and dementia. Dementia affects 6 to 10% of the people having 65 years of age or old, and this rate increases with age. The depression estimates to affect around 1 to 5% of older adults. It is depression is common in dementia, 20 to 40%, and it is a probable risk factor for both vascular dementia and Alzheimer's disease. Diabetes and depression exhibit a closely linked bidirectional relationship. 15 to 20% of the diabetics they will develop clinic depression. It is 2 to 3 times more common among the diabetes compared to without who are not having diabetes, and comorbid depression and diabetes have 2.7-fold increased risk of dementia. Next slide. In the bidirectional link between depression and diabetes, the prospective studies they're showing that baseline depression predicting incidence of type 2 diabetes and the baseline diabetes predicting incidence of depression. In the first author, you can see that more is the diabetes, more is the risk of depression. And in the second slide, B group, we can see that baseline diabetes predicting indicates more of the depression and more of the diabetes. And the first author here, if we are moving from the 96 to 2007, it is showing variable graph picture between the depression and the incident of the type 2 diabetes. And in the second B graph, again from the 2004 to 2007, the baseline varies again with the incident of the diabetes. More is the incident of diabetes, more is the depression, or vice versa. More is the depression, more is the diabetes. We will discuss further in the coming slides also. Next slide. The depression double subsequent all-cause dementia risk. A history of depression may confer an increased risk for the later developing Alzheimer's disease. This relation may affect an independent risk factor for the disease, and interval between diagnosis of depression and Alzheimer's disease were positively related to increased risk of developing Alzheimer's disease, suggesting that depression may be a risk factor for Alzheimer's disease. The meta-analytic evaluation resulted in pooled odds ratio of 2.03. Next slide. The obstacles to recognize depression in medically ill patients, the medical symptoms, they mask depressive symptoms. You have low weight, low appetite, and poor concentration due to medical illness. The serious medical illness may make depression accepted as a normal reaction. Patient is not able to express clinically that they're having depression or they're having the disease, and they two are together. The vague presentation of depression in the medical setting. 1 in 5 primary care visits are for new symptoms, and with new symptoms with no identified cause identified, because every patients who having severe depression, they are just presenting as my disease had worsened. Next. In this pie chart of the 47 patients with multiple having major depressive disorder, the only 8% or 8 patients they recognize that they are having depression, and 39%, 39 or the 9% of the patients, they were not able to express themselves even when they were visiting the clinics of the doctors. Next. In this bar chart, when we are having 90% of the depressed patients, they reported primarily somatic symptoms, we can see that in the neurological bar is more than 45% patients are having more of the somatosensory complaints, such as they are having low personal feeling, low self-esteem. They are not able to express what they want to say in the clinical OPDs, and they generally say, we are having low feelings all of the time. Our mood is not up to the mark, and it is actually the disease which is masking the symptoms, or at the same time it is a depression which is not able to give them the expression of the disease. Next. The depression predisposes to diabetes. Premorbid depression have 37 to 100% increased risk of developing type 2 diabetes risk, independent of obesity, activity level, smoking, alcohol consumption, and family history of diabetes. The mean age of onset of depression typically predates the age of onset of type 2 diabetes, and type 1 diabetes usually predates the onset of depression symptoms. And either the patient is having type 1 or the type 2 diabetes, the meta-analytical studies they have shown in the long run, both of them exhibit the depression and they both mask the symptoms of each other in the chronic long run. Next, in this bar chart, the depression versus diabetes morbidity. Patients may present with the cold hands and the feet, numbness in the hands, pain, or any kind of abnormal thirst, blurred vision, daytime sleepiness, or we can say the number of somatosensory complaints. They are more predominant in the patients for having diabetes, and it contributes to depression, which makes the diabetes worse, which further is going to worse the morbidity. Next, depression as a contributor to diabetic morbidity and mortality. Poor is the glycemic control, less adherent to dietary recommendation, less adherent to the oral treatment, increased risk for complication, which is associated with retinopathy, nephropathy, macrovascular complication, or sexual dysfunction, or any of the vasculitis features leading to the coronary heart disease, more rapid in depressed women, or it is a lower quality of life. Means depression is a major contributor to diabetic morbidity and mortality. Next slide. It is a contributor to diabetic morbidity and mortality. The higher healthcare costs, more than 4 or 5 times, and the symptoms amplification patients experience more diabetic symptoms, even when controlling for the disease severity. It may have a worse course among diabetics. The relapse rate is 5 times more higher than non-diabetics when not on prophylactic treatment. Means depression is such a great contributing factor that patient is spending more and they are gaining less. Next, depression versus diabetes mortality. In the presenting bar chart, in the first column, we can see that up to 1 hazard ratios, and at the same time, in the last, with the diabetes with depression, we can say up to 3.5, such that the risk is more than 3.5 times in the patients, or it is more than 3 to 5 times when the patient is having both diabetes and depression in comparison to the patients who are having no diabetes or no depression. Next, it is a vicious circle. When the patient is having depression, it is leading to lack of motivation, which further leads to poor management of diabetes, higher blood sugar levels, greater fatigue and lethargy, worsened mood, and again depression. Or we are just in the circle such that depression is contributing to the higher blood glucose levels, and at the same time, higher blood glucose levels they're going to contribute to the worsened mood. And in this vicious circle, patient is not going to come out easily without the help of controlling diabetes and an expert physician or psychiatrist. Next, the glycolated hemoglobin and cognitive decline. The number of charts they are showing that atherosclerotic risk in the community RIC study, when the mean age is 56 years, women are 56%, and out of those 21% are black. The mean HbA1c is 8.5% in diabetes and 5.5 in control. The diagnosed diabetes were associated with cognitive decline on the DSST scale, but HbA1c was not a significant independent predictor of cognitive decline when stratifying by diabetes diagnosis, such that more is the HbA1c, more is the atherosclerosis risk, and more is the depression. Each percentage contribution of HbA1c is further leading to more of the depression, more of the dementia, and patient is more nearing to the mortuary in the coming years. Next, what can be done to reduce developments of dementia and diabetes? Are we there to able to contribute to something? Our patient is going to live by their own? Yes, we can go for the blood pressure control, we can go for better control of diabetes, we can go for avoidance of hypoglycemic episodes, and statins can be helpful to reduce inflammation. We can go for treatment of the very good treatment of the depression and emphasis on cognitive function assessment, so that patients are able to express themselves to their doctors. At the same time, their diabetes level is very good control and their mental health is also taken care of. Next, does treatment and diabetes make a difference? In the prospective study of type 2 diabetes and cognitive decline in women aged 70 to 81 years, with in the Nurses Health study in the US, the women with diabetes who are on OHAs, they perform similarity to women without diabetes. Means patients who were treated very effectively with a very good control of diabetes, the odds ratio is just 1.06 and in comparison to 0.99, such that women who are without diabetes, means we can just go for the comparative data that if we are able to treat with a very good drugs to the patients and maintain a very good level of the HbA1c and not due to medication, they had great odds of poor performance. And women with type 2 diabetes, they have 30% greater odds of poor cognitive function than those without diabetes. Means they are having 50% increase after 15 years of diabetes, such that treatment makes a lot of difference. And we are able to express how we are able to help them in their diabetes and depression. They are able to help them in their diabetes and depression. They are able to live longer. These the studies have scientifically proved. In the hypoglycemic episodes and risk of dementia in older patients with type 2 diabetes, we are able to see in this slide that hazard ratio is additionally adjusted for the comorbidity when the number of hypoglycemic episodes, the number of dementia cases, when they are adjusted for age, BMI, race, education, sex, and duration of diabetes, or additional adjusted for comorbidities. The ratio is 1.48, 1.29, 1.86, or 2.10. But additionally adjusted for 7 years mean HbA1c level, the 1.48 is 1.44, 1.29 is 1.26, such that in each group we are getting a better control. And in the each group for the coming years, when we are studying the additional groups, they are showing better survival and lesser mortality. Next, the individualization of HbA1c goals. When we review the glycemic targets for the usual HbA1c targets, if the patient is having dementia, and if we are able to maintain with a very good level of 6.5 to 7, or if the patient is having 8.1 to 9%, there is significant cognitive impairment, hypoglycemic unawareness, there is history of falls, there is evidence of advanced or poorly controlled cardiovascular or microvascular complications, the life expectancy is less than 3 years, and the end of life or the palliative care is not so good, such that if the patient is having more of HbA1c, means 8.1 to 9%, or we are not able to individualize the goals to lower levels or 6.5 to 7%, the patients are not showing much of their better cognitive health. And at the same time, the hypoglycemic episodes, they are leading to number of the history of falls, or they are having autonomic symptoms which are not able to give them long life, and the patient life expectancy is going to fall below less than 3 years. And at the same time, when we can review the glycemic targets, when the patient is having life expectancy of less than 3 years, so that we are able to better control the diabetes level and give them a better quality of life. Next, the adverse effect of dementia diagnosis on management of diabetes. In the retrospective cohort study of around 3 lakh patients of Medicare beneficiaries with diabetes, when the 117 or the 15% of the patients with comorbid dementia, they were having in the HbA1c group who were having dementia or who were not having dementia, the adjusted risk ratio was only 0.96. At the same time, when the LDL cholesterol who are having dementia or who are not having dementia, the adjusted risk ratio was 0.91, and eye examination who are having dementia or not dementia, they were having 0.85. But when all of them were three tests were together, the adjusted predictor probability was only 36.9 and the adjusted risk ratio was 0.80. It means the dementia reduces the likelihood that individuals with diabetes will receive recommended annual monitoring for diabetes mellitus. Means if the patient is having dementia, they will not be able to stick the guidelines, they will not be able to have the recommended annual monitoring of the diabetes, and the dementia will be major contributing factors. At the same time, depression will be contributing to the dementia, and patient will not be sticking to the guidelines, which are recommended which is able to help them in the chronic go so that they're able to maintain their sugar levels. Next, this is all about the present discussion when we are going for the diabetes and the mental health at the physician level. And now we are looking forward to Dr. Sumesh Khanna, who will be discussing at the same time diabetes and its mental health perspectives from a psychiatrist point of view. And over to you, Dr. Sumesh. Then we will be taking questions for the further queries and we will be having a discussion on the topic.
Can I start?
Yes, sir.
Yes, sir.
Yeah, good evening, everyone. I'm Dr. Sumesh Khanna. I'm a psychiatrist. And thank you, Dr. Amritpal Singh Sodhi, for introducing me. I'm a psychiatrist here. I'm in Moga, and Dr. Amritpal Singh Sodhi is a very well renowned medical specialist and a dermatologist here. And I'm a small colleague of his, and I'm a psychiatrist here, assisting him in his small work whenever he needs my psychiatric help. Um, Today, my job is to help him in his job in presenting him in what diabetes can do in psychiatry. Um, Diabetes and psychiatry are related to each other in a very, very big manner. And it is not now that we are seeing this. It has been there since last hundreds of years that we are seeing this, that diabetes and psychiatry are related to each other. And many over hundred of years, lot of papers, lot of people, those even don't knew that they could be related, they have seen that diabetes and psychiatry were related to each other. Now what we are seeing now, what I'm presenting now, is a very small part of it. What I'm presenting here in a small span of time of around 15 minutes is a small part of it. In the end of it, I'll be just cruxing it in a very small um, in a small 1 minute presentation. But what I can tell you is like in a nutshell, जैसे हिंदी में कहते हैं ना कि अगर किसी को इन्फेक्शन हो जाए और किसी को शुगर हो जाए, जब तक शुगर कंट्रोल ना हो इन्फेक्शन ठीक नहीं होता, और किसी को अगर शुगर हो तो उसको इन्फेक्शन जल्दी हो जाता है. तो सेम डायबिटीज और डिप्रेशन है. अगर किसी को डायबिटीज है तो इन्फेक्शन यानी कि डिप्रेशन जल्दी होता है, और अगर किसी को डायबिटीज और डिप्रेशन जल्दी मतलब दोनों हो जाए तो दोनों जब तक कंट्रोल नहीं करोगे तो दोनों ही ठीक नहीं होते. लेट्स स्टार्ट विद दिस प्रीटेक्स्ट इन आवर माइंड. Unless we have diabetes and depression, if together in a person, and if both are not controlled together, we cannot control them individually. So let's have that in our mind and then start with uh, this discussion. So let's start with this slide, first slide. That is the link between diabetes and psychiatry. Let's start with this presentation. The first slide shows that we start is diabetes and psychiatry. First, are they present as co-occurring independent conditions with no apparent direct connection? That means diabetes is different, diabetes is different. They both occur concurrently as independent diagnosis in a person. One, diabetes as a risk factor for development of psychiatric disorders. It's true. Remember, in a person with diabetes, the person having a probability of developing depression is approximately double or three times that of a normal individual, 20% risk of more than a normal individual of having an anxiety disorder. Third point, psychiatric disorder as a risk factor of emergencies of diabetes. Let's start with depression first. If you have depression, the probability of having you as diabetes is 36% more than a normal individual not having diabetes. If you have a bipolar disorder or schizophrenia, you have 20%, minimum 20% more risk of developing diabetes rather than a normal person. Then we talk of overlapping clinical presentation of diabetes and psychiatric disorders. Yes, whenever you have hypoglycemia or diabetic ketoacidosis, you have such common presentations uh, uh, of anxiety, symptoms of anxiety which mimic anxiety disorders. And in diabetes, there's a term called as diabetic stress disorder, which is not depressive disorder, but a specific diabetic stress disorder, which mimics some kind of a mixed anxiety depressive disorder, which is neither an anxiety disorder, neither a depressive disorder, but a specific diabetic stress disorder, which improves with management of depressive disorder. Interaction of medications. There are multiple psychiatric medications, especially antipsychotic disorder, antipsychotic medications, especially the atypical um, medications, atypical antipsychotic medications, especially the atypical medications and atypical antipsychotic medications, which have such side effects which can cause diabetes. Then there is impaired treatment adherence. You should always remember that whenever you have diabetes and you have an additional psychiatric disorder, let it be anxiety disorder, substance abuse disorder, depressive disorder, any other psychotic disorder, then that person will not adhere to your anti-diabetic medication, your anti-diabetic uh, uh, anti-diabetic food uh, preferences, and that will lead to his increased glucose, his uh, increased um, increased increase in his uh, increase in his blood sugar things, and it leads increases it impair his treatment adherence. So therefore, all anti all psychiatric uh, in all psychiatric treatments will impair diabetes uh, um treatments. Implications of co-occurring diabetes and psychiatric conditions. They will always impair quality of life. They will increase cost of care. Diabetes and psychiatric uh, implications have always have doubling effect. That means all psychiatric uh, disorders will always have a doubling effect on the diabetic implications. That means they will increase the diabetic implications in the terms of the diabetic sugar levels, as well as the quality of life will depleted by the doubling effect. There'll be poor treatment adherence, there'll be poor glycemic control, and there'll be increased emergency room visits due to diabetic ketoacidosis, higher frequency of hospitalization, and higher rate of absenteeism. Depression affects negatively the glycemic control, as is shown in this chart. That if you're depressed, your HB1AC is always higher, and if you're not depressed, your HB1AC are lower, as shown in the blue rate, in the blue charts. Impact of the glycemic control on cognition, as was shown in the Accord Mind Control. If your glycemic controls are good, your cognitive controls are better, and if your glycemic controls are not good, your cognitive levels are impaired. As for the screening control, diabetes patients are screened for retinopathy, neuropathy, and microalbuminuria, and screened for peripheral arterial or CV disease if symptomatic. Cognitive impairment or dementia is often undiagnosed. Perceived lack of benefit of early diagnosis is always seen, but is always better that in almost all diabetic patients, even if they're young, then they should be screened for depression, and if they're elderly, they should be screened for depression as well as for dementia by screening them for their cognition levels. Benefits for early diagnosis detection is potential benefits of early timely detection of dementia and or diabetes are maximize their function, that means greater independence. Early treatment care can be instituted. They can improve their health and related quality of life. You can have a better clinical management and reduced healthcare costs and care management. Diagnosing psychiatric disorder among patients with diabetes. Up to 45% of the cases of mental disorder and serious psychological distress go undetected among patients being treated for diabetes due to patient and physician related factors. Sometimes patients with diabetes mellitus feel depressed but do not complain to the physician because they feel that depression is because of the diabetes per se, because of the disease per se. And sometimes the physicians do not ask for the depressive symptoms. There are different scales for diabetes or for the depression that you can ask for, but routine questions for depressions can be: how are you feeling? आपका मन कैसा है? आपको कैसा लगता है? आपका मन खुश रहता है नहीं रहता है? क्या आपको उतनी खुशी महसूस होती है जितनी पहले महसूस होती थी? आपको नींद कैसी आती है? आपको भूख कैसी लगती है? आपके मन में ख्याल कैसे आते हैं? क्या अपनी जिंदगी को आप उतना एंजॉय कर पाते हो जैसे पहले करते थे? क्या आपका मन लगता है अपने परिवार के साथ? ऐसे कुछ रूटीन के सवाल आपको जवाब दे देंगे कि आपका जो पेशेंट है वो अपनी जिंदगी को उतना एंजॉय कर पा रहा है नहीं कर पा रहा है, या उसको उदासी या उसका मन डिप्रेस्ड है या नहीं है. Routine evaluations for pain and psychological distress, whether to use things like pregabalin and gabapentin. Optimum treatment for better control and quality of life. Why diabetes is depressogenic? There are multiple factors why diabetes can be depressogenic. Multiple factors can be from genetic, quality of life, diabetes per se, the changes induced by diabetes per se. Then the neuroendocrine changes such as hypercortisolemia, leptin activity in the limbic system, altered glucose transportation, pro-inflammatory cytokines, changes in the CRP, associated with diabetes or its treatment, psychological factors like stress associated with living, poor treatment adherence, behavior factors like sedentary lifestyle, smoking, overeating. There's such common factors associated with this causal association. Among anxiety disorders, generalized anxiety disorder has been commonly associated with anxiety with this diabetes, but OCD, panic disorder, are not associated with diabetes mellitus. Some people have associated phobic disorders with uh, diabetes mellitus, but that phobic disorders is only with needle phobia, not with other phobias. Diagnosing diabetes in patients suffering from psychiatric illness. Psychosis itself increased risk for diabetes mellitus. Schizophrenia itself, psychosis, which is the commonly schizophrenia what we're talking about. Schizophrenia itself has twofold increase for itself has twofold increase for having diabetes mellitus. The first, the first degree family of schizophrenia also have much higher incidence of diabetes mellitus, and this predates use of antipsychotics. Whenever you have first generation antipsychotic use in schizophrenia, the chances of diabetes mellitus is less if it is not phenothiazine but haloperidol. But whenever you are using atypical antipsychotics use in schizophrenia, the chances of diabetes mellitus use increases many folds. That whenever you have a patient of schizophrenia with diabetes mellitus, there is an increased mortality risk. And the uses of medication, the compliance of medication is less whenever you have diabetes mellitus with schizophrenia together. The mechanisms involved in the development of antipsychotic related diabetes are unclear but includes 5-HT2A and 5-HT2C mechanisms, antagonism, increased plasma lipids, weight gain, and leptin resistance. Insulin resistance may occur in the absence of weight gain. Insulin resistance per se has been implicated both in bipolar disorder as well as schizophrenia. What I mean to say is that schizophrenia per se, as well in bipolar 1 and bipolar 2 patients, insulin resistance has been the common mechanism for their risk for developing diabetes mellitus. But the 5-HT2C antagonism, plasma lipids, weight gain, and leptin resistance are the causes for the use of antipsychotic induced diabetes mellitus causes. Whenever you use first generation antipsychotic, especially phenothiazine, that is chlorpromazine, the chances of developing diabetes mellitus increases. Whenever you use the second generation antipsychotic, especially the clozapine, olanzapine, risperidone, especially olanzapine, the chances of diabetes mellitus increases, and the DKA, IGT, and induced insulin resistance increases. OGTT, that is the oral glucose tolerance test, is most sensitive in detecting patients with impaired glucose homeostasis, especially in patients with psychotic illnesses. Depression as a risk factor for onset of type 2 diabetes is very important, and this graph clearly shows that depression increases the chance of type 2 diabetes by two-folds. Diagnosis of diabetes in patients with dementia indicates a need to reconsider aims of care and glucose targets as an indicator to review adherence to diabetes treatment and assess nutritional status, a reminder to undertake a cardiovascular risk assessment, and a prompt to review hypoglycemic risk. Next, please. Potential mediators of cognitive impairment with type 2 diabetes mellitus. There are multiple mediators of cognitive impairment with type 2 diabetes mellitus. But what are important are dyslipidemia, acute hyperglycemia, hypoglycemia, especially depression, inflammatory mediators, hypertension, and macrovascular diseases. Next, please. Mechanisms that may link diabetes and dementia. Whenever you have comorbidity, that means depression and other medications, along with hypertension, diabetes, obesity, dyslipidemia, that is metabolic disorders, with genetic predisposition, then you have multiple mediating mechanisms leading to a brain pathology, which leads to vascular, mixed, or Alzheimer's types of dementia. Next, please. There is a potential role of insulin in pathogenesis of dementia. As the aging occurs, as the slide shows, with aging, the insulin decreases, the insulin receptor decreases, and along with this, the insulin degrading enzyme decreases. This leads to beta amyloid deposition in the brain, and this increases the risk of dementia, especially the Alzheimer's types. Next, please. Cognitive impairment affects management of diabetes and treatment related complications. Less involvement on diabetes self-care monitoring because of cognitive decline. There's increased likelihood of severe hypoglycemia because with cognitive decline, what happens is sometimes you take double dose of anti-diabetic medications. Increased risk of major CV events, increased risk of injurious falls, efficient screening tools, and to establish whether early detection can improve long-term outcomes. These are the things that we should take care of when we are taking care of cognitive impairments along with diabetes. Cognitive trajectories in type 2 diabetes mellitus. Modest decline in cognition over time, even people without dementia. This affects verbal memory, information processing speed, attention, and executive function. Modest decrements affects all age groups and are slowly progressive over time. These are not early manifestations of dementia. Dementia only affects a subset of these people, possibly added effects of the Alzheimer's or severe cerebral vascular disease. Predictors of cognitive impairments and dementias in older people with diabetes. Surviving participants of Fremantle diabetes studies who were aged 70 years, of 302 participants, 20 had dementia with probable Alzheimer's disease and 60 had cognitive impairment without dementia. The major independent longitudinal predictors of dementia were older age, diabetes duration for 5 years, peripheral arterial disease, exercise which was productive, and for Alzheimer's disease, diabetes duration was an independent predictor in addition to age and diastolic blood pressure. Depression treatment always improves insulin sensitivity. As I said, that it is the insulin resistance which is important in patients with psychiatric illnesses having diabetes mellitus. Whenever you treat depression, the depression treatment improves insulin sensitivity, especially with tricyclic antidepressants. Decreased BMI, total fat mass, HbA1c, and improved cell care occurs with bupropion. Reduced depression severity predicted HbA1c in both acute and maintenance phases with bupropion treatment. That is why it is supposed that bupropion treatment is one of the good treatment agents whenever you have diabetes mellitus with depression. Mini-Cock test is a good test whenever you think that you have to test cognition of a person having diabetes mellitus. Mini-Cock test is a very easy test. Don't go with the slide. What you have to do in this test is two very important things. Give a person three very unrelated words to think. As in this example, it is given apple, table, and penny. You can give any three words. Let us say pen, 10, pen, money, mobile. Tell the person to remember these three words and then talk to him about anything for the next 1 minute, or tell him to draw anything, or ask him about the name of his daughters and son and where they're married. Just take his mind away for 1 to 2 minutes and then ask him what three things you had told him to remember. And if he remembers all the three things rightly, he is non-limited, his cognition is normal. If he remembers or recalls two things, he's fine. If he's not able to recall even one thing, then you should think about dementia. Degree of risk of diabetes with antipsychotic drugs. As I told you, whenever you are using antipsychotic drugs, if you are using olanzapine and clozapine, you are at a very high, very high risk of diabetes mellitus. Every 3 months, you should test him for diabetes mellitus. That means test his fasting blood sugar as well as random blood sugar if you're using clozapine and olanzapine. If you're using cotapine, risperidone, or phenothiazine, that means chlorpromazine, check again every 3 months. But if you're using haloperidol, you are at a safer side. But if you have to use an antipsychotic in a person who is a diabetic mellitus, or you want to use an antipsychotic where you think that you don't want to induce diabetes mellitus, then you should use either haloperidol or use aripiprazole amisulpride. Psychotropic induced metabolic syndromes. Always remember that atypical antipsychotics like olanzapine, risperidone, and clozapine are the drugs which induce metabolic syndromes. TCAs, valproic acid, and lithiums do not induce metabolic syndromes, but you should be careful when you're using them in diabetes mellitus. TCA, amitriptyline, nortriptyline are drugs which are used by diabetologists in low doses, not only as an antidepressant, but for diabetic neuropathies also. TCAs, when used in low doses, do not alter diabetic profiles. Clozapine and olanzapine can cause or increase the chances of diabetic ketoacidosis. Antipsychotic induced metabolic changes are proportional to weight gains. Clozapine can induce a weight gain of 6 to 12 kgs in a year. Cotapine can produce a 2 to 4 kgs, and risperidone 2 to 4, 2 to 3. And olanzapine, which is not written here, can also produce a change of 6 to 10 kgs in a year. Aripiprazole, as I told you, is a very safe antipsychotic and is usually weight neutral. As far as drug-drug interactions are concerned, whenever you are using fluoxetine and fluoxamine, use it with caution whenever you're using it with pioglitazone and glimepiride, because they can change their levels. But If you are using sertraline, escitalopram, then you are safe. Choosing an antidepressant, special consideration for diabetics. MAO inhibitors. MAO inhibitors are usually not available in India. Now they are available, but usually used by psychiatrists only. TCS, I, as far as the TCS are concerned, amitriptyline and nortriptyline used by used by medical specialists in doses that they are using, they are safe. SSRIs, sertraline is very good. Escitalopram is very good. They usually do not change the glucose levels. And as far as sertraline and escitalopram are concerned, it has been shown very clearly that not only they improve the blood glucose levels, but they also improve the depression in patients who have diabetes mellitus, and they also prevent the relapse in patients those who have depression with diabetes mellitus. Diagnosing depression, diabetes mellitus, the inclusive approach, exclusive approach, etiological approach, and the substitution approach. What I would just suggest is that kindly do not bother about these approaches, just bother about one thing, that whenever you have a patient that you have newly diagnosed as diabetes mellitus, one who is having diabetes mellitus, one who is having anxiety about diabetes mellitus, one who is suddenly stop taking your drugs, one whose blood glucose was under control, has was not under control, be whose diabetes was under control but not now under control, must be having some psychiatric problem or could be having some psychiatric problem. So for such patients, do look after their anxiety and the depression. And if they have some symptoms of anxiety and depression, and if you can diagnose them, kindly put them on treatment or take a psychiatric help. Achieving best clinical practice in dementia case setting and diabetes case setting. This slide clearly shows that if you are a psychiatrist doing dementia control and the patient is having diabetes mellitus, kindly take care of diabetes well. And if you're if a diabetologist having a dementic patient, kindly take care of dementia well, because both of them can play havoc to each other if they are not taken care together. Sir Henry Maudsley commented that diabetes is a disease which often shows itself in families in which insanity prevails, in the Pathology of Mind, published in 1879. This slide clearly shows that what we are saying right now is still the tip of the iceberg, because this tip of the iceberg was seen 200 years back also. And I assure you that what we are speaking is still not very well understood, not even by the psychiatrist, not even by the medical specialist. We still need to collaborate well, both psychiatrists and medical specialists together, to understand that to treat our patients well, both psychiatrists and both the medical specialists have to understand, we as psychiatrists, we have to understand diabetes very well, and you as diabetologists to understand psychiatry very well, to really justify our patients very well. And before we leave this this CME, I want to give you some take-home messages. Treat depression and diabetes together. Do not treat it alone. Depression is underdetected, underdiagnosed, and undertreated in diabetes mellitus. Subclinical depression is very, very, very common. You don't have to have all the depressive symptoms in a diabetes mellitus. Even some symptoms are very important because those symptoms are clearly going to hamper your management of diabetes. Combination of diabetes and depression is not only going to increase the morbidity, it is going to increase the complication of diabetes mellitus, and it is going to increase the mortality, not vis-a-vis psychiatry, but it's going to increase the mortality vis-a-vis diabetes mellitus, vis-a-vis all the cardiovascular mortalities cardiovascular morbidities that is going to have. Depression is always resistant and recurrent in patients with diabetes mellitus. GAD, that is generalized anxiety disorder, is very common, but panic disorders and OCD is not common in diabetes mellitus. Bipolar disorder and schizophrenia both have increased incidence of diabetes mellitus. Substance abuse is common, and smoking and alcohol both harm diabetes mellitus. Delirium in diabetes mellitus is very common. Haloperidol is very important whenever you use in diabetes mellitus induced delirium, and melatonin is very important, and its use should be encouraged and should be taught to be used in patients having diabetes mellitus and delirium. Hypoglycemia and ketoacidosis should be controlled. Lithium and valproate are comparatively safe in diabetes mellitus. Vortioxetine is a very, very important and very good safe antidepressant in diabetes mellitus. Again, sertraline and escitalopram are very good antidepressant. Bupropion is safe, but in mild depression disorders. But bupropion is not a very good in major, moderate, and major depressive disorders. Bupropion is good for mild major depressive disorder. But vortioxetine, sertraline, and escitalopram are good major depressive disorder drugs. For anxiety disorders, use escitalopram, sertraline, and clonazepam. As antipsychotics, use haloperidol and aripiprazole. Thank you, my friends, and thank you, Dr. Amritpal Singh Sodhi, for giving me this opportunity to address your friends all over India. Thank you very much, Lupin. Thank you. Thank you.
Hello, Dr. Amritpal. Sir, can you unmute yourself? You are not audible, sir.
Dr. Sumesh, sir, first of all, I congratulate you for the
Yeah.
wonderful talk, and especially the last part of the talk when you have elaborated the names of the various agents which are to be used in which kind of depression, anxiety, fear psychosis, and especially the patients who are having associated diabetes. And I think for every physician in and across India, whosoever is treating diabetes and depression, it is of utmost importance that how to select the drug and which kind of drug to be selected for treating which kind of mental illness or a mental health disease. And as far as quetiapine and risperidone are concerned, because the haloperidol has proved to be the safest agent, which is also one of the antipsychotics and in the mild doses acting as antidepressant also. But I think this is one of the wonderful assessment given by you to all of us that these drugs, when used in moderation, they can do wonders in the mental health of the patients associated with diabetes. And I am personally overwhelmed to listen to such a great kind of initiative and how to treat these kind of patients of depression in diabetes or the diabetes with depression. And one of my queries, personal query is, sir, when we are using duloxetine, because in number of patients of diabetes, we are using for the pain for neuropathies, or we are using for a simple peripheral neuritis. What do you suggest? What dose we can go for the full dose of duloxetine up to 30, 60, 90, 120, or how we should start the duloxetine in these kind of patients?
Dr. Sodhi, duloxetine is an SNRI agent. Um, Duloxetine is a very good agent, but as you know, that norepinephrine reuptake inhibitors are usually not very good drugs whenever to be used in diabetes. So what is recommended in diabetes is that whenever we use as an antidepressant, we use duloxetine at the dose of 60 to 90 milligram per day. But in as an anti whenever used in diabetes, we use it not in a dose of more than 60 milligram per day. That is 30 milligram per day, 30 milligram BD. But
That is
above
very
that,
good.
we do not recommend in
Thank you very much, sir, for enlightenment. And as the one of the audience members, she's asking, Punjab doctor, how frequently do you look for mental status of type 2 diabetes patients on insulin? Ritu ma'am, I personally want to answer your question. As far as the patients of diabetes with insulin is concerned, in every patient, we are having a printed performa in which the patient's diet and health chart is assessed. And in the one of the columns, there are 5 points, as Dr. Sumesh Khanna sir mentioned in the very beginning. आपका मन कैसा रहता है, आपको भूख लगती है, नींद आती है कि नहीं, सारा दिन कैसा निकलता है. Ritu ma'am, we assess the patients of diabetes on insulin on a routine basis for their mental health status also, and at the same time their family members are also concerned, because whenever my dietitian or my healthcare worker is assessing the diabetes patient, it is their duty to assess their mental health along with their dietary habits also. Any more queries as the
Yes,
Dr.
sir.
Vishal Dara?
Hello.
Yes.
Yes, sir. Sir, Dr. Vishesh from Telangana wants to know that as a diabetologist, what are the steps to diagnose depression if I suspect depression in my diabetes patient?
Dr. Sumesh, sir?
There are 9
Okay.
symptoms of depression,
Yeah.
and they are very easy to elicit. That is sadness of mood, decrease of interest, loss of appetite, changes in sleep, changes in your interest, changes in your fatigue or your loss of or your weakness, then changes in your thoughts like pessimism, then your death wishes. These are the various symptoms that you talk about to your patients. Then you diagnose depression, and these are easily available on net on DSM-5. Out of these 9 symptoms, you have to have 5 out of these 9 for a period of 14 days to diagnose depression. But these are only clinical criteria. You don't have to be fixed about it. You just have to ask your patients about your normal feelings. And if you feel that the patient is not able to enjoy his life, feeling depressed, not having good sleep, appetite, his energy is low, his thoughts are depressed, he's not feeling good about himself, he's not feeling good about
Thank
himself,
you very much, Sumesh, sir.
think about depression, and you can put him on low dose of antidepressant. There is no harm out about it.
Thank you very much, Sumesh, sir. One of the audience members wants to know that whether the diabetes and depression should be treated together. Priyanka ma'am, it is a vicious circle, as we discussed in these slides to begin with. The diabetes and depression, they have to be treated together, because diabetes will lead to lack of motivation and the depressed mood, which will further go for more of the depressive symptoms, which will further go increasing depression, yes, they have to be treated together from the very beginning so that the patient is able to control the diabetes level, and at the same time his or her depression is not making any changes to the control of the glycemic controls. And Manjendra
Dr.
ma'am, you
Mr.
also,
Dr. Priyanka. Hello,
yes.
Dr. Priyanka. I would just like to add one thing. Be very assured that अगर आपकी डायबिटीज कंट्रोल नहीं होगी, आपका डिप्रेशन आप जितनी मर्जी दवाइयां दे दो वो ठीक नहीं होगा. आपकी डिप्रेशन आपकी डायबिटीज कंट्रोल होगी तो डिप्रेशन की दवाइयां काम करेंगी.
Yeah.
Thank you.
Dr. Manjinder, you are thank you, Sumesh sir. Dr. Manjinder, you are asking which kind of drugs, nortriptyline or gabapentin, we are using in control of diabetes or in diabetic with neuropathy. Ma'am, we are using all kind of nortriptyline, amitriptyline, or gabapentin and mecobalamin over in diabetic patient with neuropathy. The doses which are suggested as far as the nortriptyline or mecobalamin is, I'm personally using doses up to 1500 to 3000 of methylcobalamin. And as far as nortriptyline, I just start with the 10 milligram. Dr. Sumesh will be better to elicit and then go for the incremental doses as per the patient response is concerned. And if there is no daytime lethargy or sleepiness, and the patient is getting good control with the diabetes and depression and the neuropathy symptoms, and at the what level patient gets controlled, we can just go for decremental of the doses, and the patients are often getting very good results. As far as gabapentin is concerned, if there is a concern of daytime sleepiness, lethargy, weakness, I just start with half of the tablet. After 2 or 3 days, when the patient is having not any symptoms related to any complication or any kind of new onset of symptoms with the use of gabapentin, then I go for increase of the gabapentin doses. And at the settlement of the doses, I go for increment even up to 900 milligram. I have personally used without any major side effects. That's Sumesh sir. Any comments?
देखिए with no I don't want to harm anyone's feelings, but not Triptyline 10 milligram is of no use. It is a toffee. Um,
Yeah.
55 milligram of nortriptyline is the only basic dose used for neuropathy, but 10 milligram of nortriptyline is used by basically pharmacological companies, but इसका कोई basic benefit नहीं है. But 25 milligram 25 milligram and above, yes, it has benefits, but pharmacological companies have promoted it. I'm not sure whether it works or not, but pregabalin and gabapentin, of course, have benefits. But at the dose of 10 milligram, nortriptyline has an effect. I don't agree to that. 25 milligram and plus, yes, it has a benefit. No doubt about it.
Thank you, Sumesh sir. Dr. Vishal, ma'am, you asked about any emotional stress in your patients of diabetes, and uh, you have encountered any emotion. Yes, ma'am. We encounter a lot of emotional stress in our diabetic patients, and I don't have any personal diabetes emotional stress protocol for these kind of patients for the family is concerned. But yes, family members and the diabetes patients, when they are consult together, it is having wonderful results. Often the husband and wife, they come together to the OPD for the first visit, and most of the time on the second or third visit, the family member, son, daughter, mother is there, and the emotional factor is more pronounced when a type 1 diabetes patient, especially a female who is of marriageable age and going to marry in the coming 1 year, 6 months, 3 months, then it is totally different scenario, because people in my state, they don't go for disclosing that our ward or our sibling is having diabetes, and at the same time, they are not even disclosing their this disease to their in-laws after getting married. And whenever these kind of habits they pronounce in the society, it goes for lot of complications. Yes, we do consult the family members and the patient also, but the scenario is different in the different parts, and I don't personally have any protocol for these kind of patients. Sumesh sir?
I couldn't hear that question.
Sir, it is in the chat that Have you often, how often have you encountered emotional stress in your diabetes patients? Do you have any practice protocol in place?
Uh, uh, as far as emotional stress is concerned, देखिए, every diabetic patient has an emotional stress. There is no doubt about it. But practice में करते हैं नहीं करते लोग, I don't know. But I myself, I'm a diabetic, and the day I was diagnosed as diabetic that day, and today also, whenever I have a slight rise in sugar, or maybe an uncontrolled sugar for 10-15 days, and I'm emotional stress, that is always there. क्यों नहीं होगा emotional stress? Even if I'm a psychiatrist, that emotional stress does come up. That is always there. Diabetics do have that emotional stress, and that diabetic stress or diabetic distress is a very true term. That is not a disorder per se, but that distress, diabetic distress, is a very common and a true term, which doesn't need a treatment, but it is a term which true to its name.
Sir, I can share one incident. I have around in the past month, one of the patient who is type 1 male, he has not disclosed his diabetes level to his wife. Even his wife is now pregnant, and he goes to his chacha's house. वो अपने चाचा के घर के पास जाके सामने जाके रोज टीका लगाता है, सुबह दोपहर शाम का। और उसकी बीवी को अभी 8 महीने के बाद भी पता नहीं कि मेरे पति को शुगर है। This is the kind of state of affairs. Today I see one parent only that my daughter is getting married next month. Can you shift him from insulin to oral diabetic agents so that we are able to marry her, and then we will see what happens in the future. This is the kind of emotional outburst what we are getting in a routine from the patients. Any more queries? Most welcome.
Sir, thank you for your educative talk, but sir, there are no further query.
Okay. Thank you, Ankit, for the beautiful session. I think Dr. Sumesh Khanna has enlightened us with a very knowledgeable and one of the very precise, even the name of the drugs, what should be used in the which kind of patients. And at the same time, the beautiful audience, I personally thank all of the doctors who have attended to the talk, and to the Lupin also for making us part of the family of the doctors who are having these kind of talks, especially for the diabetes and the mental health. And Sumesh sir, thank you so much. And I personally thank Lupin team for this kind of enlightenment. And we are looking forward to it for the future also. Thank you very much, everybody. Thanks. Had a lovely evening and good night.
Okay, sir. Sir, thank you very much for your insightful and educative talk, sir. So, sir, can I end this session?
Yeah,
Sure.
you